Assalamu alaikum. The long clinical consultation day. First scenario, Julia Smith, 40 years old female, presented with difficulty in swallowing for 3 months. Please take history, examine the patient, address her concerns. Yes, here you go.
Hello, I'm Dr. Abdullah Halmanla. I am one of the doctors here. Is this Mrs. Julia Smith? And you are 40 years old.
Yes, I am Julia.
Mrs. Julia, I am here to ask you some questions about your condition and examine you and address your concerns. Is that all right?
Yes.
Could you describe to me what has happened?
Yes, doctor, I have noticed that I have kind of a difficulty in swallowing, and this has been going on for the last 3 months. And I have noticed that this is something which is progressively getting worse.
I see. And when you say progressively worse, how so initially was it with what type of food?
I mean, it is mainly to both solids and liquids, but now I feel that it's getting a little bit worse in terms of the problem.
Okay, I'm sorry for that. And can I ask you also, do you notice any choking episodes? Are you choking with water or food?
No.
Okay, and so what things have you noticed that make this swallowing worse? Anything in particular?
No, actually, whatever I eat, I do feel that I have difficulty in swallowing. I have to take a sip of water, and
Okay.
yeah.
And do you feel from the beginning initiation of the process is difficult, or like from the mouth, or is it where exactly it is stuck? Do you
I
feel?
mean, it feel like, I mean, kind of it is stuck in my upper chest. So I don't feel that it is stuck in my throat. It seems it's going through my throat, but as soon as it go down, I feel it's stuck, and then I have to take a sip of water, and then it goes down. Yeah.
Okay. And so have you got any uh, different time of the morning and night between this, or is it worse in a night or morning or?
Uh, no, I think that it's kind of no specific time. Whenever I eat, it happens to me.
Okay. And do you get any feeling of acid in like uh, burning in your chest also after you eat, for example?
I mean, yeah, I have this burning feeling for quite some time, and my doctor has given me some omeprazole for that, and this has been quite a long-term problem. But I feel that this current problem that seems a little bit different. That is why my doctor feel that I need to see you.
Okay. And so have you got any change in your weight? Have you noticed?
I think that I might have lost a little bit, and
Uh,
I feel that
can
it. I
you,
mean, I feel that it might be due to the fact that I have not been eating much because I have that difficulty. So you can say maybe around 2 kgs in the last 3 months or so.
okay. And can you describe to me any lumps or bumps anywhere in the body? Have you noticed?
No,
Okay. And can you describe to me any night sweats?
no,
Any loss of appetite?
no,
Okay. And I want to ask you, have you got any soreness in your mouth?
no,
Any dryness have you noticed in the mouth or the eyes?
not really. No.
Okay. Have you got any uh, back passage? Is it any alteration in that back passage? Is it more hard than usual? Is it looser than usual?
So you're talking about the bowel motions.
Yeah.
Yeah. No, I haven't noticed anything. They seem pretty much okay.
Okay. Any bleeding anywhere? So any black stool, black?
No.
Okay. So have you been diagnosed with any past history of known medical condition?
Yes, as I told you, my doctor has been treating me for this acid reflux, and this has been for the last more than 10 years.
Okay. And apart from that, have you got any surgery, interventions, history?
No.
Okay. And what medications you are on?
I mean, I was only taking omeprazole and that's it.
Okay. For how long?
As I said that
And
it's
what is
kind of,
the
yeah,
dose?
it's kind of off and on. So I know that when my symptoms get a little bit worse, I do increase the dose, but generally I don't need to take it on a daily basis. It's the kind of thing which I take whenever I feel that my reflux. And initially I thought that may be the
Okay.
problem. So I increased it to 20 milligrams in the morning and 20 at night. But I think that's not working.
Oh, okay. Not working. You mean not working for the reflux?
No, for this problem, the solving problem.
For this
And
problem? I
yeah,
see.
I know that, as I told you earlier, doctor, that I feel that this solving problem is different from my reflux. It's this symptom. I don't feel that
Yeah.
I have the reflux at the moment. Yes.
Yeah. You truly said. And what about any change in the medications recently? Any medications apart from that? Any over the counter before your symptoms, before the 3 months?
No, I have not been taking anything else.
Okay. And any, I mean, non-steroid like painkillers for specifically?
I'm not taking any medication, and I have not used any medications for years
Okay.
apart
Okay.
from omeprazole.
And do you smoke or have you ever smoked?
I do. I mean, I take a couple of sticks a day for the last around 7 to 8 years.
Sticks, you mean how many
Two
cigarettes?
cigarettes.
Sorry.
Yeah, 2 cigarettes a day.
Okay. Um, well, I will take the chance now to tell you that smoking is adverse on your health, and we would appreciate that you would try, and we will help with that if you want to stop smoking.
All right, I will consider that. Yeah.
Okay. What about drinking alcohol?
I mean, very minimal, just over the weekend. And
Oh,
generally, it's not more than a
how
unit or two,
many?
maybe around 1 to 2
Okay.
units over the weekend. Yeah.
Okay. Okay. And have you got any family history of conditions of similarity, of difficulty in swallowing?
Not difficulty in solving, but
Mm.
my mother used to have a cancer in the large bowel, and she was treated for that. Apart from that, no, just and my father had hypertension. That's it.
I'm sorry for your mother diagnosis. I hope she's well.
Yes, she's doing
And
well. Yeah.
okay, and any okay, and do you have any allergy to any medication that you know of?
No,
Okay, um, okay. So um, I will ask you questions. If you can ask me yes, answer me yes or no, please. Do you
mhm.
get any dizzy spells?
No,
Have you been told you are paler than usual?
no,
And have you got any, do you get any itchiness in your skin anywhere in the body?
no,
And have you been noticed that your eye white part changing to yellow color?
no,
Okay, and have you got any headache
no,
or any chest pain,
no,
any palpitations or feeling your heartbeat jumping,
no,
any shortness of breath?
no,
Okay, and have you got any weakness in your arms or legs?
Yes, I do feel some weakness in my arms and also my legs as well.
Okay. Where did it start? In the arms or legs first?
I think that I've noticed it's pretty much at the same time for both.
Okay. You feel weak. Okay.
Yes, I feel that. Yeah.
You feel overall weak, you mean? All the body?
No, it's mainly, I think it's my arms and legs.
Okay. I will check. I'll see. And what about any change in numbness in or tingling in the hands or feet?
No,
Okay. Any swelling in the ankles or the
ankle.
tummy?
No,
Yeah. I'm sorry. I mean the legs.
no,
Yeah. Okay. 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 I will ask you. Do you have any history of in your family? Do you have any family history of type 1 diabetes or 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 to like conditions of the gland in the anterior of the neck, thyroid?
no.
I mean.
I told you that
Oh,
father had type 2 diabetes and my mother having that problem with the colon, but otherwise, no other issue.
I will start examination. I will check the vital signs, updated ones, and
Yeah, vital
you
signs are
will.
fine. Pulse, blood pressure, everything is fine.
Okay, I will. Do you get any thickness in your skin? Have you noticed?
I did, yeah.
Okay, and any where exactly is that?
I mean, it's around my hands and around my elbows.
Okay, and is that something worsening?
I think so, yeah.
Okay, and have you? Okay, I will check also the. So I will ask the patient to do the thickness of the to check if she would be able to do that. I will ask the patient to do that, and
Yeah, so this
also I will
will
check
get the thickness of the skin on
okay,
the.
I will check for calcinosis in the nails
Sorry?
and any pain in the hands when you get exposed to cold.
I do feel pain in my fingers, basically, especially
Okay.
in the cold weather.
Okay. Okay. And I will see any evidence of ischemia, any old ulcers or or amputated digits.
Yeah, there are few healed ulcers on the fingertips.
Okay. And any joint pains in your hands.
Yeah, I do get some pain in my small joints of the hands.
Okay. Is it worse in any time?
I mean, generally it's more in the morning.
Morning. Okay. Okay. And I will check quickly for any tenderness in where in the in metacarpophalangeal joint and the phalangeal joints.
Hmm. Yes, there is some tenderness and there is some active synovitis in the PIPs and MCPs as well.
Okay. And is the patient able to function? I will ask her to hold something, for example, a pen or anything surrounding. And is the patient able to use the hand and grip it?
Yes.
2 minutes
Okay.
left.
Okay. I will listen to the base of the chest.
Hmm.
Okay. I don't think we need to do that. And
You want to do
anterior,
chest examination or not? You
no,
you want?
no,
Okay.
no,
All
no.
right. Okay.
In the anterior of the neck, is there any swelling clearly visible?
In front of the neck, you mean to
Hello?
say in the thyroid area? No, no thyroid
Mrs.
swelling.
Julia, could you tell me what is your concern?
Yes, doctor, I'm concerned that what's exactly is going on with me.
Mrs. Julia, actually, after this assessment, I um, in top of my head more than one possibility, but I think the more One is I'm thinking about a condition called scleroderma. Don't bother with the name. It's a condition where body's defense system is attacking your joints, and in addition, it can lead to difficulty in swallowing. And we will keep you in the hospital to check with you about nutritional support and to diagnose and confirm the diagnosis and rule out other causes. Is that right?
Right. Doc,
Any other thing?
yeah, I'm very concerned because you know that I have a strong family history of a cancer. So is it possible that it's kind of a cancer?
Uh,
Because that's something which worries me a lot.
it is one of the possibilities, but it's one of the possibilities, unfortunately. Sorry.
Mm. So what you are going to do with me now?
And I need to actually we need to work as a team, support multiple team doctors, and we need to assess on your affect how much this is affecting your daily activities, and also to we need to we may need to start we will need to start medication um, to support your condition, and we may change. We will ask the speech and language therapy, which is the swallow advanced nurse, to help you modify the diet and help you improve on the swallowing issues. Yeah.
All right.
Okay.
All
Yes. Any
right.
other concern, Dr. Hisham, you want to add?
Sorry?
Any
No, that's it.
concern? Any
No, no,
concern
no,
you want to?
no
Okay.
other no.
Perfect. Let's start the examiner question, please, now.
Yes, okay. Dr. Abdullah, if you can just briefly present your case.
Yeah, this is Mrs. Julia Smith, 40 years old female. She has a history of worsening dysphagia to solids and liquids, 3 months history. She has associated 2 kilogram weight loss, and she also has um, associated sclerodactyly, and also evidence of old healing ulcers, and that's also with the symptoms of in the digital ulcers on examination. So these findings more toward the diagnosis of scleroderma
Right.
associated with esophageal dysmotility as my top differential diagnosis, my top impression. Other differential diagnosis, given her family history of colorectal cancer in her mother, esophageal cancer should be ruled out.
Okay.
Other conditions is associated, if there's any gastroesophageal reflux, although she is denying associated symptoms, or she said that's improving on history. Other conditions can lead to dysphagia. Also, least possibilities is if there is achalasia,
Okay.
given the involvement of both solids and liquids, although less likely in this case. It doesn't explain the joint involvement.
All right. Okay.
So she will need to be. I will take a full examination. I will complete my examination else also by doing urine dipstick, for looking for proteinuria and evidence of to rule out proteinuria. I will take updated blood pressure to rule out hypertension in renal crisis, and also will do a dipstick for sugar, and also we'll need to do digital rectal examination and hernial orifice examination, and also she will need
Why? Sorry, why you want to do a digital rectal and hernial orifices examination?
So given that she has a history of to rule out the involvement of to rule out to complete my examination actually. Yeah.
Okay. All right. So
yeah,
what
to
what you
investigate.
mm-hmm.
Yeah, to investigate, I will need to assess on the home conditions also, and and how much her that's affecting her daily activities. In also we will need to run starting from basic tests in terms of investigation.
Okay. Just
Blood
before
counts
going
looking
to
for
the
anemia
sorry
and any
before
active
yeah before
infection.
yeah just before going to the investigation, what you make up for the weakness? So what exactly is your assessment of the weakness she's having?
I didn't have actually. I will need to examine that actually, and that could be associated. Well, I need to examine that first. In terms of the weakness, that can be possibilities of the proximal myopathy. Also, can be associated with any associated electrolyte disturbance that can lead to weakness or generalized
Mm-hmm.
weakness in her case.
Okay. Any other possibility for the
Other
weakness?
other possibilities are associated autoimmune related conditions such as poliomyositis.
Polymyositis.
Yeah.
Right. What else?
Um,
Any other thing you want to examine apart from you said that?
of course, I need to examine neurologically the. I would like to check the power exactly in the upper limbs and to see if there is involvement neurologically as related to this dysphagia. Although I don't see any other symptoms in neurological system.
All right. Okay. How you will investigate?
Investigation basic blood tests look for anemia and full vitamin panel, B12 and folate and iron levels, active infection evidence, so CRP, C-reactive protein, white blood cell, and also to look for the liver function test to rule out any metastatic evidence in raised transaminase levels. Kidney function tests important, especially in this case is scleroderma, and also to do a chest X-ray to rule out to look for the any abnormal structural clearly seen in the esophagus. Also, she will need urgent endoscopy, upper GI endoscopy to take biopsy. Another test that can be needed is CT scan, and also she will need autoimmune profile panel for anti-ribonucleotide antibody if that's mixed connective tissue disease associated. Other autoimmune profile for SLE and rheumatoid level. So these are the
What will be your line of management?
the the management here, multidisciplinary team approach. She will need occupational therapy, physiotherapy, special language therapy, and gastroenterology, and also surgery. She will need she may need proton pump inhibitor, although I'm not sure of the line of the medications in that case to help of the dysphagia in her case. So she will need, if there is any associated candidiasis, I should have looked for that can be helped by antifungal medications, and and also in medications to help sclerodactyly. So she will need specialized input from the rheumatological team um, to look for um, also she will she will need uh, uh, so for the dysphagia she will need also proper management. Um, she may need to be given systemic steroids, uh, but that's after the discussion with the rheumatological team.
All right. Any other advice for her?
Uh, red flag. So also to be careful with the swallowing, and also until we can assess, we can allow free intake only as a better advice of the speech and language therapy. Um, I'm not sure else.
All right. Okay. All right. I think, yeah. So I think that's pretty much it.
Okay.
Thank you.
You
Thank you.
can start comment now, Dr. Hacham, please.
Right. Okay. I think that before I comment, I just wanted to ask Dr. Abdullah that
Yeah,
this was your scenario, and in the 5 minutes when you were outside, so tell me that what was your thought process and what you were thinking in terms of the differential, and then I'll start commenting.
of course. So first differential was I was thinking about malignancy. So malignancy related, or second achalasia. Goiter I was thinking about, and also scleroderma, um, and also myasthenia gravis. Um, uh, so I was putting the main lines of history taking, although I missed some of them also. So uh, um,
Right.
that
Okay.
was the
Yeah.
initial
Okay. I
steps.
think that, yeah. So if you come across, obviously, if someone having dysphagia as the presenting complaint or symptom, so when you are outside, so basically you are thinking in terms of the problem. Either the problem could be in the GIT, that could be
Yeah,
one. The second problem, it could be neurological, that's second. Third, it could be problem related to connective tissue disorder. All right. Fourth, it could be an obstruction from outside, like as you mentioned, there could be a swelling of the thyroid with retrosternal extension, and or even if there's any kind of a mediastinal mass which might be compressing on the ether. So something which is not inside the lumen but obstructing from obstructive lesions which are outside of the GIT. And then young female, you need to also consider a possibility of a functional disorder like a globus hystericus. So I think that if you keep these things in mind before going into, then your history will be pretty much focused. Now, I think that,
okay.
yeah, so I think that you missed quite a lot of details which were very important. So my point is that if you keep these 4 or 5 things in mind, your initial 2 minute screening will tell you which way the patient is going. For example, if the patient having a problem like a neurological problem, so in that case you generally expect that the patient might give you history of regurgitation of food or water through the nasal cavity, so nasal
Yeah.
regurgitation of the food stuff. And the other thing is that if you have neurological problem, so what kind of food the patient generally is unable to take? Is it for the liquid, or is it for the solid, or is it for the both?
It will start. It will be liquids more.
Yeah,
It will be
it
more
could be liquid,
pronounced
but
as
it can be, yeah, it can be solid as well. But again, the important point is that you need to see if there's any nasal regurgitation of the food, and then if there's any fluctuation, because if you are thinking in terms of anything like a myasthenia, so you need to see if the patient, and you ask it all right. So in the first two, and then you first 2 or 3 questions, you can either rule in or rule out a neurological problem. Then comes to the GIT, which you have asked. I think most of the question you asked were a bit about the GIT regarding I couldn't appreciate whether you have asked about painful swallowing. So I don't know whether you have, because I couldn't hear
No, I
anything.
didn't.
Yeah, so I think
I
that's
didn't
something.
know.
Yeah. So if it is a lesion, obstructive lesion within the lumen, so you know that it's initially going to cause problem with the solid, and then later on it will involve. So once that's not the case, and the patient have told you that it's pretty much for both, this means that an obstructive lesion within the GIT seems unlikely, because in that case you expect problem to solid first and then later on. So you can say that it's unlikely to be a intraluminal lesion causing the problem. You asked about thyroid question, I think, and you asked about any thyroid swelling and thing, and the patient told you that there was no such. So unlikely to be any kind of a retrosternal thyroid extension or things like that. Now you are left with either connective tissue disorders or hysterical patient, like it could be functional. So now focus your history more. The point is that when you make up a differential like this, that you have three, four things in mind, you can just go and get the targeted question. Now you started with the swallowing and the patient gave you history. Now you need to make an assessment. Once the swallowing assessment, you have done the swallowing assessment, all right, I think that there is no issue in that. You ask about the GIT, other questions as well, and all these things. When you reach to the connective tissue, obviously that was one of your differential, then you need to ask about the questions, which are about 8 or 10 questions, which are pretty much standard. So you need to ask, have you noticed any change in the color of your fingers, especially in a cold weather? If the patient says yes, ask about the sequence. So a lot of time they have been trained to tell you that it turned white, then blue, and then red. So the typical pattern of Raynaud's. So you need to ask about that. Have you got any joint pain, joint swelling? Yes or no, whatever is the answer. Have you noticed any skin rash? Whatever is the answer. Have you noticed any ulceration in your fingertips? Okay, no. Have you noticed any tightness in your skin? Yes, then, because whenever a patient gives you an answer in yes, always evaluate it further, because that's significant. So you know that patient have given you that I have tightness of the skin. So keep in mind, even if you're not asking at the same time, but keep it in mind that now you are dealing with a patient who has a difficulty in swallowing and uh, has a tight skin. So now your mind should work in that direction. So you need to keep in that point. I think that you need to think that okay, it is scleroderma, which you rightly pointed out. Now, apart from complete questions for scleroderma, you need to look for the other thing, especially whenever you come across any connective tissue disorder. Always look for signs of a mixed connective tissue disorder or an overlap syndrome. So how you will do that? You will ask about, as I said, that joint pain, joint swelling, rash, any oral ulcer, dryness of the mouth, dryness of the eyes, because the patient have noticed, I mean, mention tightness of the skin. So you know that you need to ask about questions. Obviously, these are private questions, but you need to ask about history of dyspareunia as well, that any problem in that. So these are the things. Then
What
what
is it?
other,
Sorry.
sorry?
What is it? The last thing? Sorry.
Yeah, so you will ask the patient if there is any problem with the intimacy, because
Oh,
due to the tightness of the private part. So at time there is a problem in that. So this is a question, if you are appearing in UK, there a lot of time they stress on that. So that's something which must be asked. Then question related to other organ system which might be affected by scleroderma. So you need to ask. You didn't ask any symptom like cough. I was waiting that you will ask about cough, because you know that these things, they are MCTD, scleroderma limited. They can be associated with pulmonary fibrosis. So you need to ask about breathing difficulty. I think you asked, but you didn't ask about any cough
cough.
or anything like that. So this is something which you need to ask. Then ask about question related to pulmonary hypertension like dyspnea on exertion. So then the patient, one hint the patient gave you obviously was that he had weakness. You didn't analyze the weakness. You need to analyze the
Mm,
weakness, because when someone say I have weakness, don't take it as a part that it
mm,
is a generalized weakness. You need to ask specifically, where do you feel the weakness? I told you that I feel weakness in arms and legs. Tell me
yeah.
which part of the arm. Is it more in your hands or is it more towards your shoulder? Then ask about specific things which I am functional disability, ask about specific things which I'm unable to do. So I would have told you I have problem changing my cloth, combing my hairs. So you now know that it is more kind of a proximal thing. Ask, do you feel any pain in your muscles as well, in your forearm or in your arm? Because myositis could be tender as well. Ask about that. Also ask about the lower limb weakness, more proximal, distal. What, how it is affecting you? Have you got any difficulty climbing up the stairs or standing from a sitting position? So these are the things which will give you further idea which way. Always ask about in a patient who have a rheumatological problem, ask about problem with the urine, any problem with the water work, any blood in your in your water work, any frothy water work. So because you want to make sure that the kidneys are not affected, which could be due to scleroderma renal crisis, which could be due to part of MCTD. So these are important questions. Rash, for example, that was also an important question which has to be asked.
Yeah.
So I think you ask bit of bit and pieces, so not all, but my point is that if you are able to get I'm sure that when you started examination and you found out that there was tight skin, I think then you were pretty much clear at least this is scleroderma. But I think that there was a hint when you were taking history and the patient told you about that weakness. So if you could correlate weakness with the swallowing difficulty, I think you would have picked up the diagnosis there, and then your history would have been more channelized and more focused.
Mhm.
In this patient, there is no need of doing the genitalia examination or offering a rectal examination. So actually, it could haunt you in a way that the examiner at time might command that unnecessary examination being offered. So it's
Um,
kind of a focused history, focused examination. The other thing in a female, I mean, because this is about the analysis of the problem, then in the other part of the history, I think that I didn't hear you asking about the female history. You didn't ask about the
yeah.
periods, pills, or pregnancy. You didn't ask about the job of the patient, that what exactly is her job, because and what impact. You ask about the impact, but you didn't ask about what exactly is the job of the patient. So these are few things I
Yeah.
just wanted to mention that I mean, when you are outside, utilize those 5 minutes in a better way and make up your mind that if someone comes with these complaints, that how you are going to approach the case. Examination wise, also don't. I think that in this case, obviously, it was important to examine the basal lungs, the bases of the lungs. It was important to examine the heart sounds, especially to look for any signs of pulmonary hypertension. It was important to examine for signs of proximal myopathy or any muscle tenderness. So these were important things I think which should have been done if you come across such a case. So from an examination point of view, I think these were the important. The patient had joint pain, so you need to analyze which of the joints, or even in the history, you can ask which of your joints are painful. Are they only painful or they are swollen as well? Just to give you a hint, because the patient told you that my pain is more in the morning, and you didn't ask about the stiffness and things like that. And regarding investigation, I think, yeah, your investigation plan was absolutely spot on. I think that I don't think that there's anything to add on that. You are on the right line of investigation, and your management was also, I think, it was fine because you involved the multidisciplinary something which you can, because you didn't ask obviously, so you didn't mention, but in the management non-pharmacological, you can ask the patient, advise the patient to keep the hands warm, wear gloves. Okay, so these are the things which help with the Raynaud's, and even you can offer in the medication, you can offer simple things like calcium channel blocker. They can help with the Raynaud's as well. And regarding, they may ask you about specific treatment, so in that case you can just mention that the treatment is mainly supportive. There is no curative treatment, but the options are, because if it is a kind of a, if you think it is myositis as well, so the steroids or even azathioprine might help, and that is something which we give as well. And even it, the methotrexate might help with the joint pain. So these are, so you can mention that there are immunosuppressant which can help with these kind of symptoms, and like inflammatory arthritis, methotrexate can help. Azathioprine can also help, and azathioprine can also help with the myositis. So you just need to need to formulate these things when you are telling the management. So I think I spoke a lot. So that was my comment. Okay, thank you very much. Otherwise, I think
Definitely. Thank you.
otherwise, I mean, your management plan, investigation plan, I think that was pretty okay. I don't think that the only thing I feel that regarding those history points primarily.
Yeah,
Yeah.
yeah. Yeah. Very important.
Okay.
Thank you so much. Nice case.
Okay, thank you, Dr. Hisham. I will add just a few comments quickly. Adding to the history, as Dr. Hisham said, whenever you have connective tissue disease possibility, analyze for others. Don't overlook it. There is something hidden. Okay? And I added in the chat box APLA for miscarriages. Always those patients will have either history of miscarriage or difficulty to be having conception. So please don't forget to add this part of question, the female history, I mean, to your analysis. You analyzed the difficulty of swallowing well, started well as a what type, what level. All this question can help you. But I felt like you are confused till the end. When she mentioned there is skin tightness, you catch the case. However, now you can again
You are
screen
right.
for other, yeah, yeah. You have to analyze and screen for other association, not only for the main cause. The weakness, as Dr. Hisham said, what type of weakness, where exactly? Whenever, not only you, any page, any doctor has a patient with weakness, ask what type of weakness. Is it stiffy or floppy? And what level? Is it distal or proximal? This is the least question to ask about any weakness. No, nothing more than
Okay.
this. If you want to analyze at least two questions, okay? Then you will know it could be dermatomyositis. Any muscle pain, as Dr. Hacham said, the dryness of the eye, all these things supposed to be as mixed connective tissue disease association plus APLA, antiphospholipid antibody syndrome. I will go now to the family history. You have to specify if you suspect cancer, ask about cancer. Any family history of cancer.
Mhm.
If she said no,
Okay.
I don't have any family history, ask about cancer particularly. Why you have positive B symptoms in the form of loss of weight, loss of appetite, which is positive in both connective tissue and the cancer. Uh, I will go to the examiner question. Or before that, you said I want to examine the chest while going through the steps of examination. Then
Mhm.
he asked you, "Do you want to examine?" You said, "No, no, no, I don't want. It's not
Because of the
important."
time.
Yeah, but don't say
Because of
it's
the...
not important. Yeah, I know it
No.
was. I think you said something which can irritate the examiner. It means that you don't care about the chest examination. No, still him. I would like, if I have more time, sir, I would like to examine the chest. He will be
Of
impressed
course.
even if you don't do. Why? Because you might have some finding in the chest, pulmonary hypertension. You might have fibrosis, okay, crackle, inspirator crackles. So don't say no, no, it's not important. I will not do this.
Of
Okay,
course.
one more. During examination, you said I will take biopsy. I think you are mentioning some of unnecessary investigation. Please be target always in the investigation. You have an autoimmune, so I will screen for autoimmune. Whatever the investigation for autoimmune. If you suspect a cancer, even in your differential, put it. But against cancer, as Dr. Hasham said, there is no difficulty of swallowing of the or of the solid. It started initially to the fluid and solid. So again, it's cancer presentation. Okay, I still want to rule out, but before doing biopsy, I can do motility test to confirm my differential first. I have possibility now of motility disorder, which is scleroderma or systemic sclerosis. So confirm the diagnosis first, then I would like to rule out after that the other differential. But I should do the first confirmatory test for my differential or my top differential, which is systemic sclerosis. One more point, the last one, steroid. Never ever prescribe steroid to scleroderma patient unless you rule out kidney affection. Okay, and
Mhm.
inform the examiner about this information. I would like to start steroid as autoimmune flare up. However, I would be cautious with this medication. Why? He will tell you, why, doctor? He will tell, yes, because of scleroderma renal crisis. So what's the other option, doctor? As Dr. Hasham said, you can give modified or medication, immunosuppression in the form of methotrexate, sulfasalazine, or whatever, or the medication you want to give. Okay? This is the only advice. Otherwise, you catch the case, you do it properly. You started as my approach, I think, by constitutional, then the relevant system constitutional, then the systemic review. However, you didn't ask some of the important questions like cough, which is very important in this scenario. But at least you went through the steps in organized way. Don't forget the the social, the job, and here also you can ask about driving if anything happened to the eyes. Remember that in autoimmune, they can present with eye manifestation, dryness, or uveitis, okay, the Zika syndrome, or Sjogren itself. So if there is any vision affection, remember the driving. This is my comment. Let's go to the next case. Dr. Abdullah, you can post the scenario. Okay. Dr. Dr. Amel, chest examination is important. This case, pulmonary fibrosis, pulmonary hypertension, exactly. Proximal myopathy, of course. It could be mixed connective tissue, perfect. Yeah, I mentioned also APLA as a association. It's important. Okay. Anyone want to add any comment or suggestion? By the way,
What is the
Just a
differential
question.
diagnosis?
okay, Dr. Dr.
Sorry,
Abdullah.
go on. Go on.
Sorry, just a question to Dr. Hisham. What's the cause of the proximal myopathy in this case? Is it polymyositis?
Yeah. So basically, in mixed connective tissue disease, you can have element of myositis as well that could lead to proximal myopathy. So in mixed connective tissue disease, you can have Sika syndrome as well, symptoms of dry eye, dry mouth, or you can have proximal muscle weakness. You can have some of the symptoms. So it is kind of a bit of pieces of different connective tissue mixed into one. So that's so the one reason potentially could be the myositis, which could be associated with that.
So,
Uh,
more pointing towards polymyositis.
yeah, a kind of a mixed connective tissue disease
Okay.
with features of scleroderma and feature of myositis.
Okay, so the differential here will be first differential mixed connective tissue disease, and second differential scleroderma, and third one it could be a cancer, isn't it?
You see that, just for discussion purposes, I think most of the time, if you come across a rheumatological case, for example, if you have seen a patient with SLE or you've seen a patient of rheumatoid, for example, so any patients who have one connective tissue disease, if the patient have some of the symptoms which might suggest that, for example, patient have say SLE, along with that there's a proximal muscle weakness, then it could be SLE with myositis or it could be MCTD. So my point is that if you put MCT in your differential diagnosis, that's what the examiner want most of the time. So it will not be wrong if you have a one rheumatological disease and you put the second as a differential, especially if you have a case of scleroderma, polymyositis, rheumatoid, or this one, so Sjogren rather. So MCT naturally come as a second differential. So here it will be, as I said, that scleroderma or MC, rather MCTD will be first, and then second number it would just be pure scleroderma. So these are the things. So
Mm.
so MCT, MCTD is one separate entity. In rheumatological disorder, there's another one which is called an overlap syndrome. So you can put that as a differential as well. So in overlap, actually, it's a kind of an overlap of different disorder, and it will not fit into any specific category. And the RNP antibodies, I think that one, yeah, the one which we do for MCTD, it might be negative. So if you found that patient have different symptoms of SLE, rheumatoid, sclero, uh, and the anti-RNP is negative, so that come under heading of overlap syndrome.
Mm. Okay.
Okay,
You
thank you,
ask,
doctor.
sorry,
Yeah.
you ask him about more differential about the proximal myopathy when he mentioned that it might be electrolyte disturbance or it might be
What do you
polymyositis.
think? What do you think,
Would you
Dr. Ahad? I will ask you this question.
um
Dr. Hisham, you can, sorry, Dr. Ahad, I will read the scenario, then we will answer this question. Mr.
okay.
Ahmed, 80 years old, has been referred by GP. He complained of 3 days history of hematuria, blood pressure 170 over 95. Dr. Hisham, 2 minutes, then we'll start. I will go back to Dr. Ahad. What do you think, what other cause or differential of proximal myopathy in autoimmune patient? Dr. Ahad.
So I didn't attend the case from the beginning, but I think it might be also related to other autoimmune disease like myasthenia gravis. Could be medication related. I'm
Okay.
not sure if the patient is taking any
Yes,
medication like
perfect.
statins or um
What medication
uh,
can give features of
yeah,
proximity
mainly statins. Um, um,
related to our case today?
steroids.
Exactly. Yeah,
Mm,
so this is one of the possible differential related to our topic and our case. Patient on autoimmune and he has or she has received steroids. So it might
she
give
has
a
received
proxy.
steroids. Oh, okay, okay, because I haven't attended the case from the beginning. That's why. Okay.
Yeah, it's a case of systemic sclerosis might be as associated with other autoimmune like mixed connective tissue disease as Dr. Hasham mentioned. Okay.
Yeah.
You have other questions?
No, thank you. Thanks.
Okay. Anyone want to? Dr. Abdullah, you were asking a question.
It's not easy actually, the management in this case. Like there are a lot of things to manage. So the dysphagia has, I forgot actually, to be honest. I need to read. Dysphagia, scleroderma, the sclerodactyly had its management. The Raynaud had its lines of management. Um, pulmonary
That's why.
hypertension.
That's why you have to mention the multidisciplinary. By the way, you mentioned the SOL team, which is very good also here. But I prefer to do it while talking to the examiner. You say to the patient, I will refer you to swallowing and speech and swallowing, or a speech and language therapy team, and maybe she
Yeah.
will ask you, what do you mean by this team? It looks something
Yeah.
complicated. Yeah, I advise you, Dr. Abdul, try to minimize the talk about other details while talking to the patient because sometimes we are saying things put us in a trouble. So try
Yes.
to be shortly answering the concern. What I have, doctor? Answer here shortly. Is it curable? Answer according to the question. First of all, you gave her time to give you express more concern. Secondly, you will not put yourself in a trouble to mention something which is not important or unnecessary to mention or jargon to use. So always be careful about talking to the patient as well as the examiner. If the examiner asks you, sometimes he asks how to manage, and you sometime mention unnecessary in this, like what I mentioned earlier, the biopsy, which is not necessary in this patient. The motility study is supposed to be the first investigation of choice. By the way, we can also mention here the achalasia as one of the differential, right?
Yeah.
Achalasia, oh, I think one of the differential because it's in the chest level. Just hold, please. I will answer this.
Yes, I think we can put ecclesia as a differential, but if we found, because it's in the exam, basically, you need to give the first differential has to be the one which cover most of the patient presentation. So if you have ecclesia, then the patient you may not be able to explain the tightness of the skin, you may not be able to explain the Raynaud's, you might not be able to explain the sclerodactyly. Yes, low down you can put it as a differential. And regarding cancer in this patient, the patient said that because of the swallowing problem, he find it difficult to eat because he's finding it difficult. And you need to, so what is a significant weight loss? You think that 2 kilogram is a significant weight loss? You didn't ask that what
No.
exactly was the weight of the patient 3 months ago. For example, if the
Yeah.
patient weight was 60 kilo 3 months ago, and now it is 58. In 3 months, he has lost 2 kilograms. So this is not significant. He might not be eating much. For significant weight loss, you need to have a weight loss of 10% of your body weight, or if there is a very rapid decline in your weight within 2 weeks' time. So that wasn't the case. And the patient told you, my appetite is fine, I want to eat, but due to the swallowing problem, I am unable to eat. So that was something which was mainly going against it possibility of a cancer. And the patient obviously in the history did not mention any obstructive symptoms as well. So cancer
Yes.
in this patient to mention as a differential was, I mean, I rather would not mention. I'll say that, okay, it could be, but seems unlikely based on, I appreciate your concern that you're concerned that you have a family history of a cancer, but I feel based on your history and examination, that possibility is low. However, when we'll investigate you, we'll need some test and these things, and including a camera test as well, and will
Yeah.
that will also rule out that possibility, but the chances are relatively less. So if you can just keep it like this, I think that will work enough for you, I think.
Great.
Okay, perfect. Okay, thank you, Dr. Hisham. Let's start your case. Ready?
Yes, I am ready.
Yeah, here you go.
Hello, hi, good morning. I'm Dr. Khizar. I'm one of the doctor here. May I confirm your name and age, please?
Yes, my name Ahmed. I am 80 years, doctor.
Right. Mr. Ahmed, I understand that you have been referred to me because you have noticed some blood in your urine. Is that right?
Yes.
Right. Can you please give me a little bit more detail about your problem? For how long you have been experiencing this problem?
So it's actually I have just 3 days history. It's quite concerning, and I noticed the urine totally is red, and
Hmm.
and also I feel generally weak 1 week for 1 week.
Right, right. I'm sorry to hear. We'll discuss about that in detail, and obviously we'll try to sort that out. Have you noticed bleeding from anywhere else?
No,
Right. Okay. Now come back to your kidney problem. Obviously, sorry, not the problem with your urine. So, have you noticed any pain on passing water?
no,
Right. And have you noticed any frothy waterworks?
no.
And have you noticed any reduce in the amount of the waterworks?
Yes, absolutely.
Mm-hmm. Right,
Has been
right,
happening over also, you can say, I'm not sure, but I noticed that is less.
right, right. Okay. And have you noticed any pain in your tummy otherwise?
Yes, I have pain in the lower of my tummy, on
Right.
the
Is
right
it
side,
right
lower
side?
on the right. Mm.
Right, right. Is it more on the front of your tummy or the back of your tummy?
In the front.
Right. Can you please point out the area which is painful?
He's pointing toward right, lower, uh, what do you call that quadrant? Right lower
Lumbar,
quadrant.
right lumbar
Like,
area.
yeah.
All right, okay. Right. Uh, so apart from that, I just wanted to ask you that.
Not lumbar, iliac, right?
Right iliac, yeah. Iliac fossa, exactly.
All right, okay. Right. So apart from that, have you noticed any increased body temperature?
No,
Right. Any change in your weight?
uh, you can, maybe I'm increasing in my weight.
Right, right, okay. Right. And how is your appetite?
Is 1 week ago is also affected with some
Hmm.
sick feeling.
Right, right, okay. Apart from this, I mean, blood in your waterworks, have you got any other symptom? For example, like any cough?
Yeah, I can cough, especially when I lie down. Uh,
For how long you have this cough?
one day ago.
So the cough started 1 day ago.
Yeah, and also I'm short of breath.
Right. And have you noticed any phlegm when you were coughing?
Yeah. It can be like a frothy phlegm.
So it's more kind of a reddish color, or what color it is?
Not sure.
All right, okay. But you said it's frothy.
Yeah,
But what I'm just wanted to ask you, what's the color? Is it white? Is it yellow? Is it more kind of
white.
a
You can
white?
say white. Yeah,
All
or
right,
pink.
okay.
You can say pink. Yeah, sorry.
All right, okay. Right. Have you got any difficulty in breathing?
Yes, absolutely. One day actually were quite bad.
And this has also started since yesterday.
Yeah, I started initially slower,
Mm.
but it's completely worsening. And
Mm.
I'm even now when I'm speaking to you, I get short breath.
Right, right. I'm sorry to hear about that. So, uh, have you noticed any pain in your chest?
No,
Have you noticed any bleeding from your nose or any nasal stuffiness?
no.
All right, okay. Mr. Ahmed, may I know that have you got any other uh, past medical history of note?
Yes, I have polycystic kidney.
Mm-hmm.
I have it also right kidney was removed, and I had a right kidney transplant 15 years ago.
Right, right,
So
right. Okay. So you
the
have the
right
trans.
kidney transplant
Mm.
has been good because I felt they said the kidney function is they want to prepare me. So they removed the kidney, and then after 3 months they put the transplant. And I'm
Right.
also diabetic after that transplant.
All right, okay. So just to clarify, so when was the last time you had a visit to your kidney doctor?
Oh, yeah, I'm regularly seeing the doctor. I'm also the kidney doctor. The diabetes is controlled well, 7.5 hemoglobin A1C, 3 months ago.
Mhm. Right, and right. So apart from this the kidney transplant which you had 15 years ago, and diabetes, anything else which is significant in terms of your past history?
No,
All right, okay. And have you got any family history of note?
um, no, I don't.
Um, Right. And can you please show me your list of the medications you have been taking?
Yeah, so he takes tacrolimus, he takes mycophenolate, he takes steroid, prednisolone, and he takes empagliflozin and Ozempic.
All right. And for how long you have been taking these medications?
Long time.
Mm-hmm. Any recent change in your medication or any increase in
No,
the dose?
no recent change.
All right. Okay. Right. And you said that you haven't noticed any recent change in your I mean, any high body temperature or anything like that.
My temperature. Sorry, when I felt unwell, I went to the pharmacy and I took azithromycin course like
When was
1
that?
week when I started to get unwell 1 week.
So you're feeling unwell since 1 week.
The general tiredness and all that, but shortness of breath is just 1 day ago.
All
You
right.
got
Okay. Right. Right. Okay. And right. So, uh, may I know what exactly you do for work?
I'm uh, I'm trip advisor.
All right. And how this problem is affecting your job?
Um, I just want to be well. No, I don't know.
And do you smoke?
No, that does not smoke.
And do you drink alcohol?
Does not drink. No.
All right. Okay. All right, Mr. Ahmed, I would like to examine you at this point. Is that okay?
Of course.
Right. I'll just examine. I'll check the pulse, and the blood pressure is
Um,
170 over 95. And yeah, I'll just look for any signs of pallor.
uh, I have image. I will show you. There is mild pallor, you can say.
Mm-hmm. Right. Okay. And I'll also look for any jaundice.
Uh, Jaundice, no jaundice.
I'll see if there's any AV fistula in place.
There is no AV fistula.
Right, and then I'll look into.
I will show you his face.
Sorry?
I will show you his face.
Sure. I'll have a look at
And
if the patient has a pedal edema.
yes, there is pedal edema.
All right,
There is
okay.
actually, you notice the swelling around his eyes.
All right, okay. Right. All right. So
Yeah, what
apart
do you
from
want to
that,
examine?
yeah, so after that I would like to examine the patient's heart.
Uh, heart is, you feel hyperdynamic circulation, but there's no murmur.
All right, okay. Then I would like to examine the chest of this patient to look for any added sounds or
Yes, basal crackles, basal.
bibasal crackles. Okay.
Photo in the chat box you can see.
Yeah, I've just seen. All right, okay. Then I would like to examine the abdomen. I'll see if there's any tenderness over the transplanted kidney.
I will show you the image of the abdomen in the WhatsApp group.
All right. I'll also look for any signs of shifting dullness or ascites.
There is no shifting dullness on examination.
Mhm.
What before the shifting dullness? What did you say? What did you check?
I'll just look for any signs of shifting dullness to look for ascites, or if it is a massive one, I'll look for fluid thrill.
No, there is no.
Right, okay. And I'll also like to look for any signs of uh, steroid-induced Cushing. So I'll look for any proximal myopathy. Have you
Yes,
felt any? Mm-hmm.
he
Sorry.
has. Yes.
All right, okay. I'll also like to examine the oral cavity, look for any oral candidiasis and also for any gingival hypertrophy.
Negative.
All right, okay. Uh, may I know, Mr. Ahmed, that how is the control of your diabetes generally?
It's controlled, doctor. As I told you, the hemoglobin A1C is 7.5, and regularly I check my sugar. It's fine.
And have you been noticing any numbness or tingling in your arms or in your hands or in your feet?
Minimal, but I'm used to that.
Mm-hmm. And have you noticed any pain while you were walking around, pain in your legs when you were moving?
Pain in my leg? No. There is no.
Right, okay. All right. And I mean, just to summarize things, so before 1 week, you were absolutely fine. Apart from that, you have a background history of a kidney transplant and diabetes. And just 1 week ago, you started having these symptoms. And now, for the last 3 days, you started noticing any the blood in the water work along with decreased frequency. And you have
Yeah.
also noticed in the last 1 day that you have been problem with your breathing. So am I
Yeah.
right? Correct me if there's anything you want to add.
You are absolutely right. But I have the
Right.
pain in my tummy also.
Sorry?
I have also the pain in my tummy.
All right. Okay. Is it a generalized kind? You mentioned it is on the right side, isn't it?
Yeah.
All right. Okay. Uh, may I know that when you are sleeping, how many pillows generally you need to use?
I need now to sleep on 2 pillows. Before I was only one.
All right. Okay. And have you ever been woke up at night feeling short of breath or
Hello?
catching air? Hello.
Yes, short of breath, and I awake in the middle of the night. Yesterday, and I did sleep. I did wake up.
All right. Okay.
Uh,
Right.
there
And
is
you,
raised GDP.
sorry? J right. Okay. So JVP is raised as well.
Yeah, and there is, you can say, in the abdomen, you didn't check something important.
I said that I wanted to palpate for any organomegaly. I also wanted to see for any abdominal
Um,
tenderness, especially tenderness over the
yeah,
transplant site.
there is tenderness. Yes,
Sorry?
there is transplant tenderness. Yes.
Yeah, I asked about that.
Transplant
Okay, so there is.
tenderness.
All right. Okay. Right. Uh.
Sorry, I didn't hear you earlier. Okay.
Oh, all right. Okay. Mr. Ahmed, may I know that what exactly are your concerns?
2 minutes left.
Yes, doctor. Is this something serious? Is my transplant in danger?
All right. I fully appreciate your concern. I think that's one of the possibility considering the symptoms you have been telling. And I think that's your valid concern, and we definitely need to rule that possibility out. Any other concern apart from that?
Is it due to the medication that I took? I'm really regretful that I took azithromycin 1 week.
Well, I think that it is unlikely to be due to azithromycin because that's an antibiotic. I think that there are few possibilities which could potentially, there's a possibility that you might have an infection which can happen when you have been taking these medication which basically
Okay.
weaken your immune system, and I think that infection likely affected your kidneys as well, and obviously I'm concerned as well that your kidney transplant might be affected as well, and that's something which we need to look into. So any other concerns?
Okay. No, thank you.
Right. So I just wanted to tell you, Mr. Ahmed, that we are going to admit you now, considering all these symptoms. We are going to admit you. We need to do some blood test, including test for your kidney functions. We need to do an X-ray of your chest. We need to do an echo, and we need to take some samples as well to check if there's any evidence of infection, which, as I said, that can happen in patients who have been taking these medication which suppress your immune system, and at time fever generally or increased body temperature might not be an associated feature. So we need to rule out that thing, and we need to involve the kidney doctors
Mm,
as well, and the heart doctor in terms of your further management. So we need to admit you, and then we take it from there. Is that okay?
that's all right.
Any other concerns? Any other concern, Mr. Ahmed?
Hello? No, 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 thank you, doctor.
All
Okay.
right. Okay.
Time is up. The questions. Dr. Abdullah, you can start.
What is your diagnosis, Dr. Tam, and what is the differential diagnosis in this case?
Yeah. Yeah. I think that this gentleman has a background history of a renal transplant secondary to a polycystic kidney disease, and also having a history of diabetes mellitus. He came in with an acute history which started 1 week ago with a generalized ill health, and now for the last 3 days he's starting having hematuria, breathing difficulties, and a cough. At the moment, I think that this gentleman have signs and symptoms to suggest that he is an acute renal failure. Along with that, he is also having heart failure. And there is a possibility that this might all be precipitated by infection. So I think that overall, my composite diagnosis is an infection which might have triggered the kidney problem and also leading to the heart failure as well. So I would like to investigate him on that line.
What type of infection you are worried of?
Yeah, I think that since this gentleman is immunocompromised, so I'm worried about a possibility of a pneumocystis infection. The other possibility could be other opportunistic infection, but I think that these things, because it started from the chest, so I would like to consider a possibility of a pneumocystis. I didn't ask about any history of contact with sick patients or anything like that, but the history is so acute, so I'm more in line of thinking in terms of an acute infectious process which might have contributed
Okay.
towards the current symptoms.
What other things you want to rule out as a differential? What other thoughts in this
Yeah,
patient?
yeah, I think that considering that he has involvement of the kidney and he also having involvement of the heart, so I would like to rule out a possibility of an infective endocarditis, which can happen in these patients and can involve both the organs. I would also like to rule out a possibility of vasculitis. However, I didn't find any systemic signs to suggest vasculitis as there was no rash, no joint pain. But low down, I would like to consider that as a possibility as well. So, yeah, so these are the other things I would like to rule out.
Okay. And how
And
how
I
you
think
will
that
investigate?
I think
Yeah.
that the other thing I would obviously like to rule out is the possibility of a transplant failure, because I think
Yeah.
that's pretty pertinent as well.
Okay. And how you will investigate?
Right. So first of all, I'd like to admit this gentleman. I would like to start with some basic investigation, which will include the blood counts, inflammatory marker like CRP and ESR, UNEs. I would also like to do a urine analysis to look for any hematuria, proteinuria, any urinary cast. I would also like to do a urinary PC, protein creatinine ratio. I would like to do a chest X-ray for this patient. I would also like to do an ECG, and I'll also request an echo as well. I would also like to do a pro-BNP level in this patient to rule out a possibility of a heart failure. In addition to that, I would also like to do some scanning for the kidney as well. That will include a renal scan, including a renal Doppler scan as well. Uh,
Mm.
so these will be my initial, and I will like to investigate further to rule out a possibility. So I'd like to send some blood cultures. I'd like to send sputum cultures as well. So I think these will be my initial line of investigations.
Okay. And
And I would,
management-wise?
yeah.
Yeah.
So regarding
No,
management, I think
continue.
it, yeah. So regarding management, I think it will be a multidisciplinary team approach because he seems to be quite complex. So I think that we need to involve the renal teams first of all, because he has a very vital organ in the form of a transplant. So it's precious. So we need to involve them first of all, just to make sure that we're not missing on anything in terms of the transplant failure. So I think that's the first thing I would like. I would also like to involve the cardiology team as well, and he might need to involve the infectious in, the in, infectious disease
Mm.
team as well. So I think these are the things which I would like to involve in terms of the management. So we just need to have a strict record of the intake and the output. We need to do the daily weight of the patient. We need to,
Mm.
because this patient obviously has been on a lot of immune suppressant drugs, so we need to isolate the patient and keep him in an isolation because he is at a high risk of infection. So we need to keep him in a side room because he might be having kind of a infection which might trigger the sepsis as well. So I think that's important. Initially, wait, waiting for the result, I think the infection should be treated in any case. So if the initial parameters are very markedly deranged, so I think that he should be covered with a broad spectrum antibiotic till we get all the results. So yeah, I think that would be my approach in this case.
Okay. Do you know any what types of renal rejection?
Sorry.
The types of renal rejection transplant?
Yeah, I think the rejection could be, I mean, it depends upon the time duration. It could be a subacute rejection which could occur within hours after the transplant. Then it could be an acute rejection which occurs from few days to I think initial few weeks, uh, and then after that we can have a chronic rejection as well. So there's an acute, subacute, and chronic rejection as well. So I think that this patient had a transplant 15 years ago, so he's more at risk of a chronic rejection. And in the initial acute or subacute, it could just be due to graft versus host disease or simple rejection, transplant rejection. But on the later stage, it could be multifactorial. It could be precipitated by infection. It might have been precipitated.
What do you think?
Sorry.
Okay, okay. Continue.
Yeah. So
What do you think about the benefit? What do you think about the presentation of generalized body overload on periorbital swelling uh, with this acute uh, shortness of breath and heart failure in this gentleman could indicate in your mind in the renal transplant background?
yes, I think that as I said, that it could just be, I mean, because people who have an acute renal injury or acute renal failure, they can go into nephrogenic pulmonary edema. So I think that's a possibility that this patient might be might be in a nephrogenic pulmonary edema, and that could explain the potential difficulty in breathing and the frothy sputum he is producing and the difficulty in breathing as well. So I think that there's a possibility that due to his acute kidney injury, he has developed a nephrogenic pulmonary edema. And
What are the side effects of tacrolimus?
yeah, for
Last question.
tacrolimus can cause a lot of side effects. It can cause hyperkalemia, it can cause hypertrichosis, it can cause gingival hypertrophy, it can cause hypertension, it can cause a neuropathy, and yeah, I think that's what I remember.
Okay. Okay, thank you.
Thank you.
Okay, time's up. A question, sorry, comment, Dr. Abdullah, please.
I don't have to comment actually. Just the because a kidney patient periorbital face puffiness was one of the complaints to be asked, and
Yes.
Also you checked about the medications, you checked about the follow-up and social history and job, and so you didn't offer something to reduce the blood pressure urgently. This gentleman has emergency, and so he may need actually critical team assessment just as a management point. And you didn't check for the tremors actually on examination.
Yeah.
Yeah, but yeah, I think that's it. Yeah.
Okay, thank you.
Okay, and what are the top differentials?
So
The cause of
no,
hematuria?
it's a discussion about acute renal transplant rejection. So I think so. Pyelonephritis you didn't mention about, but given this renal transplant pyelonephritis, okay. Obstructive, you mentioned obstructive renal allograft, and least in the list, but like least likely tacrolimus toxicity causing injury to the kidney. But after 15 years of transplant, I'm not sure.
Yeah, and other thing is, yeah, so basically, yeah, but obviously when I started, so my understanding is that after an initial analysis that this patient have a problem in the kidney, and when I analyzed it first, so I can just tell you that what I did when I was waiting for the discussion to start. So in this patient, so my differentials when I was outside, so I was thinking a problem in the kidney. I was thinking about a generalized bleeding disorder. I was thinking about any drugs which might be like the blood thinners. I was thinking on lines of certain infections, and I was thinking on line of vasculitis. So this was something which was in mind, and I have put my plan according to that. But I think that I just missed two or three things, as you have rightly pointed out. I didn't ask about the periorbital puffiness and things like that. So yeah, but
Did
I
you,
mean, my thought process was like that when I was about to start.
okay, did you ask about the trauma? It's a very important question here.
Uh-huh.
Okay,
No, I didn't
yeah,
ask.
yeah. And always remember the ultrasound for the kidney, the transplanted kidney. It's important to rule out thrombosis. Thrombosis, by the way, can cause hematuria, right? With pain.
Yeah, it can. I mentioned that, Dr. Basim. I mentioned Doppler ultrasound.
Okay, perfect.
Yeah.
Okay, so let's start as a comment. Hematuria, you want to know also, is it all through or initially or at the end? I think you missed this part as well. So,
No,
Because
it
the
says
yes, I wrote it, but the patient himself, the surrogate, told me that
uh-huh.
it's frank blood. So I'm seeing only blood. So that is why I didn't ask about, because if he would not have, then I was planning to ask whether it is in the start or is it mix or is it at the end. But he initially mentioned in the first, when I asked about that, said that it is a kind of a frank bleeding. It's all blood. So that is why I didn't ask about those questions.
But does it mean when he said frank blood means all through the stream? I think
I
you can
probably
add the question just
Sure.
to show the examiner. Yeah, is it
Okay. All right.
urethral? Is it bladder? Or is it glomerulitis?
Right. 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 Okay.
Right? Yeah.
Thank you.
Yeah, the blood thinner also you ask, which is good. Any blood from the other areas very important
Yeah.
to rule
Yeah.
out
So.
bleeding disorder. Yes. Whenever you have positive finding in the history, please don't forget to write it in the examination. What I
Hmm.
mean, the tacrolimus, patient on tacrolimus. Write down in your paper, I have to examine the tremors. I think,
Yes.
yeah, that's
I
why you
missed
miss
that.
it. Yeah,
Yeah. I
always
missed that.
put a part in your paper for examination. What system I should examine? I
Yeah.
believe in this patient, you have to examine the tremors or the peripheral signs of toxicity, even
Hmm.
bruises for steroid if he's on, cyclosporin, cytotoxicity, or signs of toxicity like gum hypertrophy. In the
Hmm.
face, you have to examine for jaundice and pallor,
Cushing.
for
Cushing.
Cushing as well. Yes. So it's complicated case, by the way. I
Yeah.
agree. It's very
Yeah.
difficult
Yeah.
difficult to have it in the exam.
I think
Unless
that Dr. Basim, I think that transplant patient they do come.
they do
Transplant,
come.
you,
Yes, yes.
yeah.
It
I
comes
mean,
as
I
short
remember
and
that.
as long. Yeah, it
Yeah,
comes.
in long case also because they ask a
It
lot of
comes.
time someone with, I mean, a wide differential, like someone presenting with infection. So they basically looking for a possibility of some
If
infectious complication, lymphoma,
mm,
or something. I mean, my point is that this is case which is not uncommon. So this can come in the exam
very
as a
common,
long
yes,
case. Yeah.
yes. I think Dr. Abdullah also bring it
also,
for a very important
did you
topic.
mention tacrolimus level?
Sorry,
Sorry?
Tacrolimus level in the investigations?
not only
Yeah, I
tacrolimus,
think that I didn't
other
mention.
medication.
But
Yeah.
yeah, I think that, yeah, so I don't know. I think that it is important in terms of looking into tacrolimus toxicity. But my point is that will tacrolimus toxicity explain all the symptoms?
No, it will show
No,
tremors,
no, it doesn't. And
signs of
also blood
toxicity.
gas.
Yeah. Yes, continue, Dr. Abdullah.
So blood gas analysis to rule out
Yes.
acidosis just as a,
Yeah,
but
blood gas.
that's emergency. But
Yeah,
given the
yeah,
patient
you're
has
right.
shortness of breath,
Yeah, yeah, you're
and
right. Blood
there is
gas is good.
something, there is a interesting point. When I looked for this, they said LDH can be as a workup because this patient has a differential of uh, is, so so ischemic necrosis to rule out ischemic necrosis in the transplant. If LDH is normal, that's less likely.
Uh-huh.
If it is normal, this will be toward rejection, immunological rejection. Just as a
Right.
test, LDH to do. Yeah.
Yeah, I know that LDH was important in this patient if it would have been chronic and we are thinking about a lymphoma secondary to immunosuppression, but this is new for me. So you're saying that we need to do the LDH, and if it is normal, this means that there is no ischemic necrosis of the transplant.
Yes, that's guiding test.
All
But I'm not
right.
sure how sensitive to roll out. Is it like 100, like how much sensitive? I didn't have a number about how
All
much
right.
sensitive to get a
All
predictive
right.
value.
Yes.
Right. Right.
What
Okay. Thank
about
you.
the amount? Is it important to ask about amount of urine in such case?
Yeah, very important. So that
Mm,
indicate acute kidney injury, acute kidney
exactly.
failure. Yeah,
Yes. So
yeah.
here you can again put the rejection or infection or recurrence of the disease, original disease as a differential. Don't ever forget them as a
Mm.
differential for any transplant. Rejection, infection, or recurrence of the main disease or original disease. Plus, extra, if you want to mention drug toxicity or other infections or lymphoproliferative post-transplant lymphoproliferative disorder by name, they want to hear that also.
Mm.
Be sure that
Mm.
you mention it. Okay, it could be also one of the complications due to the immunosuppression. The other examination I want to comment about the chest you mentioned, the cardiac, raised the renal transplant itself. You have to do the all steps of examination and try to focus on the tenderness. If there is
Yes.
tenderness, so you are having a patient with rejection, possibly or infection.
Yeah. Yeah.
So put it in your mind or usually.
Yeah.
Other comment, I think we are covered the most important topics here. The azithromycin, I don't think it was something, it was just to distract,
Yeah, yeah.
unless he mentioned amoxicillin. What do you think if this medication was amoxicillin? We have discussed this
Why?
case before. Is it important if the patient mentioned amoxicillin? Yes, I have sore throat and I have taken the amoxicillin, and now he presented with this hematuria. What do you think the importance, along with
I think
fever
that
and rash?
uh,
Uh,
I mean, if someone
yeah.
having a sore throat and develop renal involvement after 1 week, so one thing I can think of is the possibility of IgA nephropathy, and
2 days IgA nephropathy, 2 days, yeah.
yeah, and if it
And
is more than 2 weeks, then I could
yeah,
think about a post-streptococcal glomerulonephritis.
perfect. Yes, they
Yeah,
like to hear that. But I
yeah,
meant the this sorry, not this the amoxicillin for another condition, and I said we discussed it earlier or before, couple of weeks ago.
mm,
Interstitial nephritis. Some patient,
right,
whenever they took this amoxicillin, they have rash along with the fever and acute kidney injury or hematuria. Could
right,
be there.
right,
There is often interstitial nephritis, and you will have eosinophilia in the urine.
right, right.
Yeah,
Dress syndrome, basically.
this is another.
Rash, eosinophilia, and systemic symptoms. Or
Yeah,
no, that's different.
this is
Sorry.
another
Yeah,
yes,
yeah,
different things.
acute
Yeah,
interstitial nephritis. Okay,
yeah,
that's fine.
interstitial nephritis. Okay. Yes. Thank you, Dr.
Because
Abdullah and Dr.
I
Hacham.
think
Any
we
other question?
didn't.
Yes.
I
Sorry.
think we didn't have a full analysis. Like like ideally we should discuss the hematuria. So
What do you mean by more
hematuria
analysis?
has a thorough analysis actually. So
We mentioned
like we
about
can
the
get the chance to.
Dr. Basim, just wanted to ask you, based on the history,
yeah.
um, what I mean, down the list, can we put infective endocarditis as the differential because it present all acutely?
Yeah, it can present with glomerulitis, and you
Yeah,
might have hematuria,
and also heart involvement as well.
and he's immunocompromised. But what
Yeah,
are
so
the risk of infective endocarditis in this patient? I mean, any procedure recently, any surgery recently, any injection mark recently, or
but
just for the immunocompromised and
yeah, I mean he is
transplant.
immunocompromised. So if someone is immunocompromised,
But
so
I also he didn't mention any valve involvement.
yeah, examination of the heart was normal apart from the raised JVP.
Yeah, actually, to put it as a possibility to be complication, but not to be a differential.
Right, right, right.
But it could be there as if there is particular if he has a history of procedure, for example. So it could be the reason of the infection spread.
Hmm. All right, okay.
Okay, but it's still one of the possibility with infective enteritis, patient might present with renal pain and also hematuria as a glomerulitis, immunological deposition or immunological phenomena as they mentioned. Okay, it's good to think
Right.
about it, but think about more renal case or renal conditions,
Mm-hmm.
particularly related to the transplanted one. You have a lot of differential you can put here, as I mentioned, infection, rejection, and recurrence.
Yeah.
Then you can say also, I could think about infective endocarditis, just roll out it by doing blood culture, for example.
Mm. And regarding the management, and when the patient was asking about, so do we need to stop or suspend the empagliflozin if we are thinking in terms of infection or an acute
Yes.
kidney injury? So we need to tell
Yes.
the patient that we need to stop your
Yes.
medication.
Yes. It's important to mention any medication should be adjusted according to the renal and the renal creatinine or GFR or creatinine clearance. You have to
Mm.
say to the patient, please hold on your medication. We will review with the transplant team and along with the kidney doctor. And then we will update you what you can stop, what you can take. That's a very
Mm.
important point.
Yeah.
I remember now also one comment regarding previous case for Dr. Abdullah. He asked about over counter, then you denied it. Then he specify another question for non-steroidal.
Yeah.
So I think it's the same over counter, the same as non-steroidal. So just to save the time, not to repeat the question. It's the
I
same.
think that, yeah. So I think that if you can just ask, have you used any over-the-counter medication?
Yeah.
So I think that cover everything. Like if your patient have used any non-steroidal or any, because there are a lot of
Yes,
things which are
exactly.
available over the counter. So if you just ask, have you been using any over-the-counter medication, any herbal medications or anything like that? So I think that
Yes.
cover all rather than asking. Yes, I think that, like for example, today in, I think in Lahore center there was a case of upper GI bleeding. If that's the case, in that case, I think you specifically need to ask, have you been taking any pain medications, and just ask about the name, because in that case, if you just ask, have you been using any over the counter, so it will be, in that case you need to, because you're looking for a specific drug, so
Yes.
just ask about, have you been using any pain medication or any other.
Particularly.
Yeah,
Yes.
so that's important. So it all depends that what exactly is the scenario.
Yes, it depends. Yes, you're right. But I want to save the time more. Over counter in medicine means any medication not prescribed by the doctors.
Yeah.
Usually they are painkillers and usually they are non-steroidal. S- See, this is the point. Okay. Anyone? Sorry, you have any question, Dr. Ihtisham or Dr. Abdullah? Any comment?
That's it from my side. Thank you.
I
Okay,
think
thank you.
also in the analysis, they lower urinary tract symptoms of obstruction. So the retention and the nocturia and urgency, and also if there are visible clots, just to add.
Okay.
All right. Okay. Thank you.
The stones as well. You can ask.
Yeah.
But yeah, I think the hematuria itself should be screened first. Then, if you want to ask about others urinary or other urinary questions, as you mentioned, the stone, the gravels, the amount, the frothiness, all this makes sense. If there is pain, you have to analyze the pain, where is the pain exactly, where it goes, and the scale of the pain. Don't forget it. I don't think there was pain here, or it was painful. Dr. Abdullah, it was painful, right?
It was pain in the site of the transplant, so
Okay, so it's
it's
only there, yeah. But you have to ask, is it referred or radiated by, you mean it goes anyway? Why?
yes.
Because you might suspect pyelonephritis or you might suspect stone passing. So please don't forget this question. If the pain is localized to the transplant, so means it's kidney issue or transplant related rejection or infection, as I mentioned earlier. Okay, thank you, Dr. Abdullah and Dr. Hacham. Quickly, I
I
will
just
go
would like
through.
to add some
Yeah, yeah, yeah,
point.
yeah. No, no. Go, continue, Dr. Ahad. Yes.
Just I would like to just add some point in the history, but it was already mentioned by Dr. Basim. So all the like bleeding from other orifice and medication use, and as he mentioned, and also like screening for the lower urinary tract infection symptoms like dysuria or burning micturition. So this is very important. I would like just to add some point in the investigations and management that we usually do in our renal ward. So because he mentioned about the tacrolimus level, this is very important. So every transplant patient that has been admitted, either like of suspected infection or due to any other cause, tacrolimus level should be added to the investigations. Okay. So it could be sign of rejection due to high so both high supratherapeutic level and subtherapeutic level could be related to rejection. So due to tacrolimus nephrotoxicity or
But
subtherapeutic level of the tacrolimus.
what's
So the tacrolimus
the
level is very important. Is very important part of the investigations. This is the first thing. The
yes,
second
perfect.
the second thing is you can also add BK and CMV level. because this patient has been presented with flu-like symptoms, I think, or sore throat in the beginning. So it might be related to CMV infection, especially in the transplant patient. So even in a transplant patient that has been admitted with infection, even if we are thinking of pyelonephritis, we add CMV and BK level. It's very important opportunistic infection in transplant patient. Also, so there is aspect also in the management that I've been asked this question in one of the renal interview before. That I have actually the same presentation, transplant patient presented with pyelonephritis, or graft pyelonephritis, and they asked me about the management to the no, the steps that I can do in the immunosuppression. So they meant at that time that I should double the bread because the patient has been had the infection at the time being, and also in the practice we usually hold the MMF. So you can add this point. This is very important point, and they can add the bonus to you in this scenario. I
Okay,
think
Dr. Ahmed,
this is
I want to add
my
a question
points.
to you. Dr.
Yeah.
Ahmed, what do you think other medication can cause renal failure, particularly in this
You
patient?
mean in transplantation?
Yeah.
So as I mentioned, supratherapeutic level of the tacrolimus. And this patient,
Yes.
he's taking MMF, he's taking prednisolone. I don't remember is there any other medication that has been taken by this patient. Others, others,
No, no, not on this patient particularly. I mean, in general, what is the most common to affect or to cause kidney injury or kidney failure?
medication wise.
Yeah, related to the transplant.
So yeah, there is other medication like non-steroid anti-inflammatory drugs can cause also if the patient is taking like some antibiotics, obviously diuretics, BBI. So there is like list of medication that can cause.
What about cyclosporine? Is it common to have cause?
So cyclosporin toxicity, I think, can cause renal failure. So
Yes,
um
it can cause.
yeah,
Yes.
it can cause renal failure, but this
Yeah, it
patient is
can
not
cause.
taking.
Yeah, this is my question actually. So you have to add to your levels cyclosporine level. It's not only tacrolimus. So this is my question.
This patient is not taking
Yeah, yeah,
cyclosporin.
yeah. I said in general, not in this case. I mean in
Yeah, in
general.
general, yeah.
Yes, yes.
No, if the patient is taking cyclosporin, definitely you should put cyclosporin level. But
Yeah,
the
yeah.
patient, yeah. So the patient either taking cyclosporin or tacrolimus level. In both cases,
Yes,
you
you
should
have
put the
to.
level of the immunosuppressant. So this is regarding the management. Just asking why you haven't put good pasture syndrome in your differential list. Patient is
As
presenting with hematuria and coughing
okay.
of
What do you
pinky.
think? I will ask you this question. What do you think? Is it possible to have or to put it in the differential? Tell me when you can put this is a differential. Tell me exactly. First of
I'm not.
all, is it possible?
Um.
Okay, there is
You mean
possibility.
autoimmune? Okay. Yeah. Yeah. Autoimmune disease. The
No,
patient
it's
is
not
taking.
autoimmune. It's antibody against the basement membrane. But when you to put it here in such age, what do you think?
The
70,
ages again is to be honest, but I'm talking about the
yeah,
presentation itself. So
80 years. Do you think good basher can come in such age?
it's not common to
Okay,
be honest.
so what we can say, or what we have to find in the history to say this is good basher, and I mention it in brackets during my comment. It's one of the complication of any transplant. Anyone knows what could be?
Hemoptysis, pulmonary hemorrhage.
Yeah, of course you have to find the pulmonary hemorrhage hemoptysis. No, what I mean, why you can say this is good basher in such age, or when you can say this is good basher in such age. Not only rejection, Dr. Kani, it's recurrence of the disease. If he had earlier good posture and he had transplant post the syndrome, now again the antibodies newly formed or reformed and they attack the new kidney. So I can say this is recurrence of the disease, which was, for example, in good posture. You got it, Dr. Ahad and Dr. Kani and others.
No, but it can. I mean, it can be a new like event in this patient.
Yes, could
But
be,
but
but
but the pulmonary manifestation of
yeah,
good
supposed to
posture,
be.
generally it is a pulmonary hemorrhage. This patient does not have any history of
Yeah, I'm talking about general. So
No.
recurrence, antibodies recurrent or
So
recur back. It could be the
yeah.
case. Okay,
Yeah,
continue,
I
Dr.
got your point. I got your point. But I mean, this could be a first, like a new event
Could
in
be,
this
of
patient.
course, could be. It could be, but I said would be more better, or it would be more common if the patient is have or had the history of good posture earlier and necessitates transplant. But it could be, yes, why not?
Yeah, I got you. I wouldn't put this in the first of my differential. To be honest, this is should be at least the like the least bottom of the differential. I will put the transplant rejection due to pyelonephritis. Can be as he mentioned that obstructing
Perfect.
manifestation. And the third thing I might be like considering good posture. Again, it's not the age I can see, but
The age
still
and
still the
pulmonary
patient
symptom.
having hematuria and like coughing something looks like a blood.
Mhm,
Pulmonary hemorrhage could be a manifestation of good posture syndrome, but it doesn't present in any patient with good posture. It's a complication.
mhm.
So I will consider it, but the least bottom of the differential, to be honest, like giving the patient having hematuria and coughing
Oh,
something like a blood.
okay, thank you.
Um,
Perfect. Thank you, Dr. Ahad. Anything else you want to add?
no, thanks, thanks.
Okay, thank you too. The other comment from Dr. Amal, I think this case transplant dysfunction top of differential presence of signs of overload. Important to ask about other symptoms of uremia and ask about chest pain, uremic pericarditis. Perfect. So it's one of the systemic review question. Whenever you go through the systemic review, you are asking about chest pain. Okay, Dr. Mustafa, rejection versus infection, exactly. Interstitial nephritis. Dr. Ashima, why there is here failure in the diagnosis of this case because of the GVP raised? This can reach to volume overload, reflect to the volume overload. Exactly. So again, any rejection or any infection can cause acute kidney injury of the transplanted kidney. So the patient will present with overload, puffiness and raised GVP, lower limb edema. So it means dysfunction. Again, the dysfunction because of infection, rejection, or recurrence of the original disease. So it's the same. Fluid overload, of course, it's the presentation or the manifestation in the examination. Okay, anyone has other comment to add?
I think, Dr. Basim, if we think like this, so in that case, I feel that even if I can put a diagnosis or differential of sepsis with multi-organ failure, I think that I can also explain this as well, that the patient have been unwell for the last 1 week, and obviously because he was on immunosuppressant, he was not taking. I mean, we don't expect the patient to have fever and things, but it started with a feeling of generally unwell, which we normally see in elderly population, and then develop renal involvement and then the heart involvement as well. So it could just be an infection which might have triggered multi-organ failure. So I think that could also be one of the differential in that case.
Yeah, sure. You have to add also dizziness, feeling dizzy while standing from sitting because
Yeah,
of the hypotension, signs
because
of
we have,
injection,
yeah, because we have
fever.
evidence of at least two organ failure, at least because the kidney is failing, and also there's evidence of heart failure. So if it started just with a feeling of unwell and being given antibiotic, so there's a possibility that there might be an infection which was not being appropriately picked up or treated, and now he has developed a multi-organ failure. So we can explain that way as well. So it all, I think that could also be one of the differential down the line.
So you will add to your investigation also acidosis, lactate, and
Yeah.
neutropenic sepsis as leukocytic count is down, or even you have fever, high grade fever. So you have to find other manifestation of sepsis or neutropenic sepsis. Yes, it could be one of the differential, and you have to rule it out. But you will find other manifestation of neutropenic sepsis.
My point is, Dr. Basim, that if patient is immunocompromised, and obviously in elderly people, we don't normally see high grade fever, so they present with unusual symptoms. So it can, the sepsis in these kind of patient can present without a fever as well.
Yeah, I agree. As I said, but you have to find the other sepsis markers or sepsis signs. Okay. So here, patient presented with volume overload rather than being, for example, dehydrated. So I can think about it if he's having pre-renal or hypotension or fever or not. You can add also to your differential or your investigation the inflammatory markers along with the acidosis, the hyperlactatemia, as I mentioned. But to mention it as top of your differential, I don't think it could be there because of the volume overload. But still, you can suspect infection in such age with immunosuppression medication or suppression situation. Yeah, it's okay to mention it, but I don't think they want it in this case. It will be guided by another manifestation or symptoms if they want to say this is neutropenic sepsis. Okay.
I have a question, Dr. Basim. So in this case, when you are asked about the management, uh, it will be as an emergency, right? Say this rehab renal transplant, a surrogate patient, they don't bring real unwell. So say he has a renal transplant tenderness site area and these symptoms. You will start ABCD or approach or uh,
So
is better, right? Yeah.
yeah, it depends on the presentation. As I said, if the patient is dizzy, in the presentation, he said, I feel dizzy. You suspect there is volume depletion. If you suspect he's hypotensive, as Dr. Hisham suspect the neutropenic sepsis, but here it goes more with the overload, not as hypotension or hypovolemia. Other thing, if he has any uremic manifestation, you have to say, I would like to start with ABCD. For example, patient is confused, trying because of uremia, I mean uremic encephalopathy, along with the acidosis, all the things will guide you to start with ABCD approach. This such patient, he's still maintaining, he can talk, he doesn't have any uremic symptoms. Yes, there is tremors, but it's not flapping one. It's tremors related to the tacrolimus. So I don't think this patient need to be resuscitated because he's still, as I said, he's overloaded.
But Dr. Basim, this patient is definitely for admission because he
No, I
has
didn't say
he,
don't
he
admit. Yes, of
yeah,
course you have to
because
admit.
he has been showing signs of heart failure. So we need to look into that, and seeing the heart failure seems to be quite a problem because he said that even if I speak, I become short of breath and
Yeah, yeah.
all the features. So I think that this patient will be for urgent admission and all these things, A, B, C, D. You need to check the oxygen saturation, you need to do the blood gases, and you just take it from there. So it
Yeah,
is not,
I
yeah,
remember now one word he mentioned that he has frothy, right, in the briefing.
yes,
Yeah.
yes,
Yeah.
yes.
Yeah, so for this, yes, I could admit emergency and I will stabilize oxygen saturation, secure airway if he has fortification, but it might be in pulmonary edema. Yes, definitely you have to mention ABCD in such
Yeah.
condition. But I talk about volume overload in general, with which is not affecting the oxygenation or the oxygen or breathing
Yeah.
of the
But now
patient.
here the problem is that the patient have breathing issues, so we need to take immediate
Yes, of
action on
course,
that.
ABCD will be.
Yeah.
And renal biopsy is not something to mention because it's tricky, I
No,
think.
no. I
And
think
the
that it
LSD,
will be too much premature to
Too
say that.
early, yes. Too early
Yeah.
to say
So I
that.
think that
It's
you just need to find out first and then take it from there.
so before mentioning it, you have to mention the ultrasound Doppler. Okay.
Yes. Yeah.
Even some investigation related to the kidney function, the drug level. If the examiner level of the questions reach to this extent, he will tell you what else, what else, what else. You have to mention the renal biopsy of the transplanted one. Okay. And it will be
Yeah.
followed by the transplant team.
But I think Dr. Basim generally in 5 minutes of
No, no, no.
discussion,
They will not reach. Yes, yes.
most of the
Difficult.
time, yeah, it doesn't reach to that level.
Yeah, but the most important, more than the renal transplant or renal biopsy, is the Doppler ultrasound. It's very important. You have to mention it.
Yes.
Okay. Yeah, it's a screening
Yeah.
tool of a transplant.
Yeah.
Okay.
Yes, nice discussion as usual. Thank you, Dr. Hisham and Dr. Abdullah. Anyone else has any question? Anyone want to add any comment? Satisfied all? Okay, so thank you everyone for the attendance. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Assalamu alaikum.
Alaikum assalam.